Welcome to part 2, Lympho-vascular terrain dysfunction and the dynamics of health. I'm Ivan Dubin. I'm an osteopathic practitioner based out of Vancouver, Canada. And this is part 2 of the lymphovascular terrain series. And there will be more to follow. You can find part 1 on my Vimeo channel or from my website at ivandubin.com. From an educational point of view, this presentation is part 2 of the lymphovascular terrain series. The goal of this presentation is to examine the role that lymphovascular terrain dysfunction plays in the increased incidence of lifestyle-related chronic conditions related to hidden inflammation, tissue degeneration, and metabolic dysfunction. I will compare the cost of the body maintaining homeostasis in the form of allostatic load and its implications in chronic health complaints that are trending towards disease, but have yet to achieve the parameters associated with the degeneration of terrain. The idea is to view the human body as a somewhat closed ecosystem with its own distinct terrain. General overview: be examining lifestyle-related health trends and the role of the lymphovascular terrain. We'll bring an osteopathic perspective on pathophysiology. We'll talk about the concept of viewing the body as having a terrain or ecosystem within the homeostasis framework. Examine the current crisis in lifestyle-related dysfunction resulting from broken terrain or terrain fatigue. And we'll talk about the concept of allostasis. Continuing the overview, I'll discuss the importance of considering edema as an osteopathic lesion, discuss osteopathic lesion patterns or adaptations leading to dysfunction within the lymphovascular terrain, discuss dynamics of immunity, resiliency, mucosal barriers, and the importance of a diversified microbiome, bringing the terrain theory to life within the connective tissue system and the ECM. Some clinical questions to ask are: can the presence of edema be considered an osteopathic lesion and an indicator of potential hidden inflammation, tissue degeneration, and metabolic dysfunction? With my current understanding and perspective on the function and form of the human body, can I sufficiently shift the physiological trend away from dysfunction towards improved terrain and resiliency? And how will I know when I'm influencing a shift in the terrain and the dynamics of health? A quick reminder of some aspects of the structural component of the lymphovascular terrain. In principle, this image exemplifies the interrelationship of the various components of lymphovascular terrain. Important to remember, this dynamic is always under some degree of tissue pressure, combined with tensegrity and chemical gradient imbalances. So here we can see this is just giving you an idea of how the arteries, the veins, the lymphatic system, and the cells, as well as the interstitial fluid, all work together in a matrix forming a type of terrain. The only thing not present in this diagram are nerves. Best way to understand the lymphovascular terrain begins not necessarily with the lymphatics, but with the architecture and the function of the vascular tree. In particular, two dynamics we want to remember is that moving from the heart, the blood flow moves from the center to the periphery, up towards the cranium as well. And opposite of that, we have the blood flow moving from, in the venous system, from the periphery back to the center in the opposite direction, coming from all areas, including the cranium. Basic image of the lymphatics does not give you full appreciation and the ability to distinguish between deeper and superficial lymphatics, which I'll cover a little bit. later. And this is just meant as a general review. If you want to see a bit more, go to part 1. You'll see a lot more information. But again, just reminding that we've got the arterial system that's moving blood from the center to the periphery in all aspects, going up to cranium as well. And when we're looking at lymphatic or venous system, it's going back against the flow of the arterial system, keeping in mind that it's more of a passive movement. Arterial system has some sense of sympathetics driving it out to the extremities, but the venous system is subject to pressure gradient imbalances as it tries to make its way back down, back up towards the vena cava and towards the heart. Now keep in mind also that in this relationship we also have the diaphragm, which is approximately here. And so the diaphragm is creating a negative pressure above and positive pressure below the diaphragm, which affects the way that blood is coming back up through the system. And it's also having a profound effect on the ability of the lymphatic system to come back. Now keep in mind that the lymphatic system itself is indeed moving from the periphery back towards the center where there's a thoracic duct, and same thing with the right side. Important to remember. Also to remember that the lymphatic system is divided up into 2 sections, where you have the left side of the head, cranium, both legs, and the left arm. They are part of one lymphatic system that typically drains here at the left venous angle. And then the right side of the cranium and the right arm and aspects of the mediastinum drain here into the left venous angle. So there are effectively 2 different systems. We also want to keep in mind that because we have this presence of the diaphragm and the positive and negative pressure gradients, we know that this thoracic duct going up through the center and its connection to the venous angles can be influenced greatly by pressure gradient imbalances both above and below the diaphragm. So coming back to the vascular tree, what I'm going to do here is just again put in the diaphragm here, and then as I discussed, the lymphatic system is moving from the periphery back up through to the center to the venous angles. And of course, as I mentioned, the division of the lymphatics between the left side and the right side. The topic of pressure gradients is very important in understanding lymphokinesis in general. The human organism relies on optimal pressure gradients between tissues and organs in order to sustain homeostasis, an example of structure governing function. The simplest example of this is just blood pressure. The pressure inside the lymph capillary is about 100 mmHg at rest, and the flap valves are closed. Lymphokinesis is reliant on optimal tissue pressure gradients. Tissue resistance and compression results in an accumulation of pressure, lymph, and toxicity. The human body is essentially a metabolic sponge of varying densities with fluidic concentration gradients, tissue pressure gradients, connective tissue tensegrity, and ideally optimal microbiome diversity. Optimal lymphatic flow requires that tissues reflect ideal pressure gradients and chemical gradients, since they surround the vascular structures and act like three-dimensional sponges. The functioning of the heart and arteries require optimal pressure characteristics to sustain blood flow demand and requirements. And that's not just in the structures themselves, it's in the surrounding tissues. The more density in and around organs or tissues, the harder it is for the body to maintain its blood pressure. In the foot of a standing person, the arterial pressure is about 200 mmHg, but the venous return flow is only 100 mmHg. The pressure in the venous system steadily falls the closer it gets to the heart. Lymph pressure is lower in the initial lymph vessels, and it elevates centripetally until it reaches its maximum at the thoracic duct. Consider the architecture of the vascular tree, working from the center to the periphery, while the venous and lymphatic flow travels from the periphery back to the center. Looking at Ohm's law, the blood volume flowing through a blood vessel section depends on the pressure gradient between the beginning and the end of the blood vessel section and the resistance in the region. The flow resistance depends on the blood and its viscosity, the radius of the vessel, and the length of the blood vessel. The narrower the diameter of a vessel, the more resistance, and that decreases the volume of blood passing through it. Blood viscosity influences the blood volume to a much lesser extent than does resistance. Now, Foldy talks about this resistance, and again, we're talking about tissue resistance, which is made up of connective tissues and fluids and muscle. So these are all aspects that are involved in limiting blood flow in and out of an area and lymph flow in and out of an area. Continuing with Ohm's law, the pumping motion of the left ventricle provides a mean blood pressure of about 100 mmHg inside the aorta. Initial flow resistance in the main arteries is also 100 mmHg until it reaches the small arteries, such as the radial artery, where the flow is now at 85 mmHg. So it's harder to deliver blood further away from the center towards the periphery. That's a clear reduction of 15 mmHg. The next significant junction of flow resistance occurs at the precapillary arterioles. This is where we use the term peripheral resistance, as it occurs at the precapillaries due to the decrease in the diameter of the precapillary arterioles. Now again, we're talking about the superficial lymphatics when we're talking about the precapillary arterioles. And I'm going to again remind you that there's a deeper lymphatic system which is also a slave to the pressure gradients and pressure within its respective arteries. Moving away from blood pressure specifically, let's go into lymphokinesis, which is the movement of the lymphatic system. Lymphokinesis requires ideal tissue pressure. The blood contains about 150 to 200 grams of plasma proteins circulating in total for the entire body. During a 24-hour period, a minimum of 50% of this plasma amount will leave the blood circulation through the process of diffusion. This occurs mostly through the post-capillary venules and into the interstitium. As a result of this extravascular circulation, the lymphatic protein load is received into the lymphatic capillaries and is transported back to the blood circulatory system through the lymphatic vessels. Notably, the accepted viewpoint has been that only 10% of the blood volume enters the lymphatic system in a 24-hour period, which would seem an understatement considering that 50% of the blood is made of plasma, and that according to Foldy, 50% of the plasma enters the lymphatics within a 24-hour period. I think simple mathematic deduction would indicate that it must therefore be a minimum of 25% of the blood volume entering the lymphatic system within a 24-hour period. Knowing that this is the case, does imply that 1/4 of the metabolic activity in the body is dedicated to lymphokinesis, the result being a greater emphasis on the role and significance of the lymphatic mechanism. A critical component of lymphovascular terrain is the organ known as the interstitium. This is a critical aspect that is subject to alterations in chemical gradients and pressure gradient imbalances. The increased pressure will lead to lymphostasis and increased lymph production. This contributes to a negative feedback loop of potential edema and tissue degeneration due to the inflammatory markers. When mechanisms that are required to protect against edema fail, the results can result in an increase of interstitial pressure and a reduction in the effective ultrafiltration rate. So lymphokinesis slows down. The effective ultrafiltration rate will remain unchanged if the interstitial pressure does not change. Lymph formation will increase if there's an increase in interstitial pressure. This explains why all cases of generalized edema primarily appear where the fluids can easily accumulate in the area of the interstitium that is most compliant. An example would be the eyelids or the scrotum upon waking, as the general lymph flow is sluggish at night due to immobilization. Some basic guidelines coming from the American Osteopathic Association Journal, Foundations for Osteopathic Medicine. This is including liberate the artery and restore blood flow, removing the resistance which exists under forces of compression, contraction, and compaction to restore optimal blood flow in and out of the tissues. The traditional approach aims to recognize which portion of surrounding tissues may be compressing an artery, adapt a treatment protocol designed to alleviate the compression and restore healthy blood flow once again. And within the circulatory system, the heart is responsible for generating the pressure differences across tissues. I go into more detail on the heart and its influence in the mediastinal lymphovascular terrain, which is part 4 of this series. This is another example of lymphovascular terrain, a schematic drawing of the epidermis and dermis, and we can see in green the lymphatic system, in red the arterial, in blue the venous, and the anchoring filaments of connective tissue, which are intermingled between all three. That's known as the interstitium. There's also a fluid component, and this entire system is what we are managing when we're talking about compression. It doesn't have the nervous system included in this image, so there will be some portions of interstitium that have nerves running through. Another rendition, also subdermal, but again, this one really giving a picture of the complexity and the diameter of the vessels as they become thinner at the top and thicker the closer they go, the deeper they go into the body. Another area that's susceptible to pressure gradient imbalances is the cranium and the base of the skull and the cervical spine. I'll talk more about that in the next presentation in part 3 in cervical and cranial lymphovascular terrain. But having a look at this image, what we can pay attention to is the interaction between the green lymphatics, the arterial system, in this case the carotid coming up into the temporal bone, and the venous system. So we have this dynamic where there's a flow of blood that's coming in and lymph and blood that's coming down. So what ends up happening is the key critical component is the base of the skull and the foramen, which influences the flow of blood coming in and out of the cranium, and in which case would affect the total pressure of the entire cranium. Maybe not so much in the frontal bones, but definitely the 3/4 of the cranium would be susceptible to pressure. Briefly touching upon this topic, this is coming from Osteopath Torsten Lehm. The cardiac and respiratory rhythms exhibit cycles that interact in phases, and they are synchronized with the rhythmic cycles produced at the brainstem. This is accomplished by some cell groups situated at the brainstem that participate in the cardiac tonicity, cardiac rhythms, and respiratory rhythms. The basal ganglia development of the brain is the result of compression phenomena as the brain expands around the third ventricle. It is also supported by a hydrostatic pressure of the ventricle and the information it receives from the hydrodynamic heart output, along with the increased volume of liver expansion. Now, this is an important distinction here, because we're including the liver now, which is dominating as well in the vascular system, speaking more to the idea that the pressure gradients in the cranium could be influenced by liver expansion. Continuing with the topic of pressure gradients, moving down through the body, we can see the deeper lymph nodes that are visible once the heart is taken out of the picture in the mediastinum, noting the influence that the heart, lungs, and diaphragm could have on potential pressure gradient imbalances. So we've got the diaphragm down here, and then you've got these deep lymph nodes that are supporting the aorta, supporting the bronchus, supporting the aortic arch. These nodes also connect, which you don't see here, they connect to the thoracic duct, which would be traveling up here through the center of the body. Also important to note that if we're just looking at the heart itself, we can see that it's well supported by lymphatic nodes outside of the pericardial bag. And in the part 4 presentation, I go to high detail with the heart, and even showing the lymphatic system that is underneath the pericardium, supporting the muscles of the heart directly. Within the lungs, we have lymphatic structures that reach the alveoli, which would also be susceptible to pressure gradient imbalances or chemical and particle irritants. Also of note are the lymphatic vessels located in the subpleural connective tissues and the lymphatic vessels accompanying the bronchus and the pulmonary veins. Below the diaphragm, we have the deep lymphatic nodes that are supporting the various organs, such as the stomach, liver, and pancreas. We also have splenic lymph nodes. Pressure gradients at the epigastric area can certainly contribute to lymphostasis, especially as the lymph coalesces towards the cisterna chyli and then leads into the entrance of the thoracic duct. Also, it has been determined that some individuals do not present with a cisterna chyli, although the lymph still makes its way to the thoracic duct entrance. If we're just looking at the epigastric area, we're talking about this central area here, and you can see the collection of lymph nodes that are supporting the aorta as it's forming its celiac plexus, and any extra tone in the aorta or pressure is going to influence the flow of lymph coming back towards the thoracic duct entrance, and of course that thoracic duct extends and begins to go up towards the venous angles. At the pressurized environment of the small intestine, we can appreciate the arterial system, venous system, nervous system, and the lymphatic system are all interconnected. any expansion of the microvilli pressure gradients leading to a contraction or expansion will alter the capacity for local lymphokinesis, especially in the context of chronic degenerative diseases such as irritable bowel disease or celiac disease. This image allows us to see the pelvic bowl and the lumbar lymph node constellation with the bladder removed. Note how the size of the nodes can vary, as is the case with the nodes surrounding the common iliac artery and veins. Obviously, pressure in the pelvic bowl will impact lymphokinesis in the area. This image shows the pervasiveness of the lymph nodes supporting the rectum and anal canal. Almost all the arteries have accompanying nodes, which could lead to lymphostasis if arterial pressure changes, such as in the case of hemorrhoids. This image allows us to follow the deep arterial system and the accompanying lymph nodes into the lower extremity, down to the foot. These nodes are not commonly revealed on a traditional body map of the superficial lymphatic system. This is a deeper lymphatic system. This image allows us to also include the notion of tensegrity altering lymphokinesis, as would be the case with excessive dural tension affecting the lymphatic vessels supporting the emerging spinal nerves. This is where we have those lymphatic vessels supporting the spinal nerves as they come out of the canal. Lymphatics are also supporting the metabolic activity occurring in our bones. Blood and lymphatic vessels form a versatile transport network and provide inductive signals to regulate tissue-specific functions. Blood vessels in bone regulate osteogenesis and hematopoiesis. Using high-resolution light sheet imaging, they found that lymphatic vessels in bone tended to expand when exposed to toxicity or stress. Now, these are the vessels within the bones. Secretions of lymphangiocrine, or lymphatic endothelial cells that normally reside near the crypts of epithelial cells inside the intestines, also support bone regeneration with their secretions. This image supports recent findings that during injury there's an increased number of lymphatic vessels present within bone to support the self-healing process. At any level of the lymphovascular terrain, there's a possibility of degenerative processes and cellular death. Preceding the pathological state would be a progression of deterioration, or what I'm calling terrain fatigue. So this terrain fatigue can obviously occur in and around bones. Even if it's not an injury, you can still get a deterioration due to the presence of the lymphatics in the area. Cellular degeneration is possible if those lymphatics are compromised. Referring back to this process that we're calling terrain fatigue, how common is it for an individual to develop a pattern of dysfunction in one or more of these regions of lymphovascular terrain? Cognitive decline, cardiovascular, digestive dysfunction, urogenital issues, degenerative bone dysfunction. Prior to any type of deterioration or degeneration of tissues establishing itself and evolving into something more cynical, there's likely a trend of terrain fatigue. Again, coming back to this image of lymphovascular terrain, the interaction of all the cells, the interstitium, the different fluids, keeping in mind this image doesn't include the nervous system. But when we start to get a degenerative process occurring within this environment, then we can have vulnerabilities occurring at any level. Toxicity or stasis within this area can cause damage in any of these structures. Obviously, individual lymph nodes can also be susceptible to local or regional pressure imbalances within the connective tissue or arterial systems. The lymph nodes can be easily overcome by either tensegrity or pressure gradient imbalances, or both, and I would argue even chemical gradients in the form of toxicity. Here we can see that within each lymph node is arterial and venous support coming in and out of the node. This implies that lymph is being processed along the way in each lymph node, as well as generally moving back towards the terminus at the venous angles. What's important is that one way or another, certain aspects of lymph make their way back into the bloodstream. So if we're looking at this idea of terrain fatigue, how does it coincide with some of the chronic health complaints that people are struggling with? For that answer, we're looking to lifestyle health dynamics. Overwhelmingly, people are struggling with lifestyle-related health complaints. This can present as chronic pain or any type of a itis. Another example would be metabolic dysfunction, such as type 2 diabetes, often accompanied by a myriad of hormonal imbalances. Other common concerns are chronic issues such as lowered immunity, poor digestion, sleep disturbances, skin disorders, edema, anxiety, frozen shoulder, gout, recurring infections requiring antibody use, which would be in the itis category, weight gain, degenerative mental disorders, autoimmune disorders, migraines, and headaches. Much of the lifestyle complaints arise from processed food, toxicity exposure, blood sugar mismanagement, overabundance of stressors, and sedentary habits. For example, sitting is now referred to as the new smoking. As far as sitting as the new smoking is concerned, according to the Mayo Clinic, research analyzed 13 studies of sitting time and activity levels. They found that those who sat for more than 8 hours a day with no physical activity had a risk of dying similar to that posed by obesity and smoking. Research has linked sitting for long periods of time with a number of health concerns. They include obesity and a cluster of conditions such as increased blood pressure, high blood sugar, excess body fat around the waist, and unhealthy cholesterol levels. These all make up metabolic syndrome. Too much sitting overall and prolonged periods of sitting also seem to increase the risk of death from cardiovascular disease and cancer. Clearly, there's a trend towards a loss of adaptability, viability, and overall quality of health in regard to lifestyle-related health dynamics. The trend towards lack of viability is represented by the body's terrain that has areas of congestion, hidden inflammation, and eventual tissue degeneration. Managing the terrain really means managing health. There's a distinction between fitness and health. Fitness can contribute to health, but health is not likely to occur just because of fitness. In an ideal world, we're looking at optimizing nutrition with unrefined real foods, without chemicals, additives, pesticides, or genetic modification, clean air, clean water, reducing hidden inflammation, optimal sleep hygiene, managing stress, participating in community, endeavoring to express one's full potential, and contributing to humanity with purpose. You want to monitor health with a medical doctor or a naturopath that practices functional medicine, supported by regular comprehensive lab workup. Movement and exercise to support circulation and detoxification pathways. Aligning with ideal body weight and composition is critical, as many of the chronic health conditions are associated with obesity. We can look at intermittent fasting, microbiome management, blood sugar or insulin resistance management. And I'm not necessarily talking about pharmaceuticals. Manual therapy can help at supporting homeostasis by reducing the presence of allostatic load, by decreasing hidden inflammation, and restoring optimal blood flow to tissues and organs, allowing for optimal detoxification, which can reduce inflammation and promote the maintenance of epithelial and endothelial cells, as well as the structured water phenomena within tissues and mucosal layers. The structured water is sometimes called magnetized or hexagonal water. It refers to water with a structure that has supposedly been altered to form a hexagonal cluster. Recently, based on results of studies presented at a magnetic field strength of 1,000 to 3,000 G, we find that water is capable of exerting beneficial effects, while water treated with field strengths greater than 5,000 Gs may result in detrimental effects. The animal research conducted today consistently demonstrated best beneficial effects of structured water consumption. It comes from Lindinger, 2021. You'll find that in my bibliography. In addition, the dynamics of health rest upon a functioning lymphovascular terrain, which functions like its own ecosystem. One aspect of the biological health is comprised of delivering oxygen and nutrients to tissues and organs via the vascular tree. Another aspect of health, often underappreciated, is the detoxification pathways involved in the removal of carbon and various toxic proteins and substances, including of the body and not of the body, things that are a metabolic byproduct and things that are byproduct of metabolizing foods. In addition, the entire connective tissue system, ranging from bone to tissues of all densities to blood and other fluids such as lymph, completes a three-dimensional living bioplasmic matrix called the lymphovascular terrain. Pathophysiology within the lymphovascular terrain can be a combination of tissue and fluid tensegrity dysfunction, pressure gradient imbalances, electromagnetic disharmony, metabolic resistance, and microbiome dysfunction, all of which can increase inflammation and cellular degeneration. The following definitions are coming from British osteopath Tom Dummer. They can provide a basis for understanding the trending stages of moving out of health towards disease. How we view the role of homeostasis in regards to the disease process is important in understanding the fact that maintaining homeostasis comes at a physiological cost. The first physiological stage, is purely functional disturbance phase. Second is physiopathological stage, with continued functional disturbances and some structural tissue changes. At any given point, the pathological process can occur. The third stage, pathophysiological stage, where it becomes a semi-permanent structural tissue change with worsening symptoms and functional disturbance. In addition, during the third stage, there can still be some homeostatic balance and integrity of tissues sustained, even though it is unsatisfactory. And finally, the pathological stage, with increasing structural tissue change and more functional disturbances and symptoms. The final stage is where the line between degenerative and terminal pathology leading to imminent biological disillusionment presents itself with a complete breakdown in homeostasis. Now, if we're looking at the concept of homeostasis, let's delve into the osteopathic perspective. According to British osteopath Tom Dummer, homeostasis can be described as a motion towards stability and uniformity within the various normal body states. Stability is characterized by dynamic stability, and it is constantly oscillating between specifically well-defined limit set points of activity. He says, health is defined therefore as being an adequate state of adaptation, compensation, and dynamic equilibrium. This is necessary not only within the environment, but also within the organism itself. Common examples of homeostasis are arterial or baroflex pressure homeostasis, core body temperature homeostasis, volume of body water homeostasis, blood glucose regulation homeostasis, potassium sodium and calcium homeostasis, pH of extracellular fluids, oxygen carbon dioxide homeostasis, and plasma pH homeostasis. Mechanisms involved in management of homeostasis include thermoreceptors, mechanoreceptors within connective tissue and muscles, respiratory control center, renin-angiotensin system, cellular nuclear receptors affecting gene expression, otherwise known as epigenetics, osmolarity lymphatic system, which is meaning the pressure of the lymphatics, stretch receptors in the aortic arch, carotid sinuses, and the internal carotid arteries, and neurotransmitters in the central nervous system. All are mechanisms of trying to manage, tools the body will use to try and manage homeostasis. There are no guarantees that dysfunction will be avoided even if relative homeostasis is maintained within certain set points. In many instances, a person can maintain physiological set points but still complain of symptoms. They'd be lifestyle related, like poor sleep, weight gain or fluid retention, fatigue, joint pain, constipation, digestive disorders such as IBS. Almost all syndromes can occur within homeostasis parameters. The axes within homeostasis are the HPA, hypothalamic pituitary adrenocortical axis, the hypothalamic pituitary gonadal axis, the hypothalamic pituitary thyroid axis, renin-angiotensin aldosterone system. The SAS, sympathoadrenal system, the glucose insulin system, the neuroendocrine immune system, brain monoaminergic system, hepatic detoxification system, very much connected to the lymphovascular terrain, cellular signaling system, and the reduction oxygenation system, and the ghrelin-leptin angioponectin system. All examples of axes that are working behind the scenes to try and manage homeostasis. Is there a cost to the body for managing homeostasis? There are physiological consequences occurring in the individual which are the result of maintaining those ideal physiological parameters. These are considered dysfunctions which have not yet evolved into a disease state. Many of these dysfunctions are managed by suppressing the negative byproducts of sustaining homeostasis. This is not yet a disease state, but is instead a trend towards the potential outcome. The cost of overactivation of homeostasis has its own descriptive physiological state called allostasis. Now, when I talked about management by suppressing negative byproducts, we're talking about using chemicals to manage the symptoms that someone might have, such as blood pressure issues or blood sugar issues. According to European osteopath Torsten Lehm, talking about overactivation of homeostasis leading to allostasis, overactivation of this heterostatic homeostasis state was seen as contributing to a functional collapse. The two behemoths of physiological concepts would dominate the medical ideology until 1981, when Sterling and Eyre questioned whether homeostasis and heterostatic concepts were enough to explain why many observed functional phenomena occurred. They suggested that actual state of internal physiological adaptation and balance was not static at all, and that it was in fact a process of constantly changing internal physiological and mental states that were acting to manage the demands coming from the internal and external environment. Continuing with overactivation, The process of overactivation of homeostasis is called allostasis, and it describes a process in which the organism succeeds in maintaining internal viability by physiological and behavioral changes of state. Total functional integrity requires the ability of the physiological and psychological state to adapt and change. Here, the set point is more of a moving target rather than a stationary physiological anchor. So this speaks more to the cost for the body of maintaining homeostasis is allostatic load and allostasis, which I'll discuss in more detail and how that presents in the physiology. The concept of an allostatic state is further proposed to be a chronic overactivation of regulatory systems and the resultant alteration of physiological set points. Subsequent results of a prolonged state of allostatic load leads to a state of allostatic overload and the expression of a pathophysiology. Allostatic load pathologies are linked with the presence of cortisol, cytokines, and catecholamines, and that's coming from Lymph. This discussion on allostasis is coming from Shulkin, 2004, entitled Allostasis, Homeostasis, and the Cost of Physiological Adaptation. It's produced by Cambridge University Press. And it's precisely the state of allostasis that I refer to when using the term terrain fatigue. Homeostasis can be seen as a system of regulatory responses designed for sustaining life, and allostasis can be seen as a specific regulatory response designed to maintain internal balance. Allostasis is a state of adaptation which tests the viability of the organism. There is a physiological cost to the adaptation, and it is typically known as a pre-disease process diagnosis. For example, type 2 diabetes being regarded as prediabetes. Here the set point is more of a moving target rather than a stationary physiological anchor like in homeostasis. It is a chronic overactivation of regulatory systems with the resultant alteration of physiological set points. Other examples of terrain fatigue include chronic fatigue syndrome, fibromyalgia, chronic infections requiring subsequent antibiotic usage, cancers. Also, allostatic load will affect the nervous system by leading to behavioral changes, including depression, cognitive capacity reduction, memory loss, and anxiety. Allostatic load can lead to insulin resistance, increased blood pressure, hyperlipidemia, hyperglycemia, and metabolic system via the adaptation of the endocrine system. Indicators of allostatic load include weight gain and fat deposition, high blood pressure. Blood panels reveal low, high-density lipoprotein, blood sugar imbalances, and hormonal imbalances. Another indicator is poor quality of digestion, poor sleep quality. Most medications are designed to suppress symptoms without altering lifestyle choices. This is a good indicator that you are under some type of allostatic load. With the allostatic state, allostasis involves local feedback as well as brain and body connections. This requires a more complex form of homeostasis, which at times presents a narrow set of limits. The degree of allostasis is defined as the allostatic state, and this involves the chronic expression of overactivated regulatory systems and the alteration of set points. There are, however, other set points that are more variable in terms of regulatory systems, and still the capacity can be overloaded. This overload has been termed allostatic overload, and it is represented as a pathophysiological expression as the result of a chronically overactivated regulating system. All systems have limits. Allostatic state involves chronic imbalances in the regulatory systems, which are instigating the overproduction of certain mediators such as cortisol or inflammatory cytokines, and the underproduction of other mediators. This would include common diagnoses like chronic fatigue syndrome and fibromyalgia. Again, that's coming from Shulkin. When the allostatic state is cumulative, it turns into an allostatic load that is reflective of the overactivation of allostatic responses. Further markers of allostatic load include abdominal fat deposition, left ventricular hypertrophy, high cholesterol, type 2 diabetes, low high-density lipoprotein present in blood panels, arteriosclerotic plaques, hypertrophy of the hippocampus, chronic pain, and fatigue that is associated with immune mediator imbalances. We can also interpret allostatic load as the cost to the body of having to adapt repeatedly to the demands placed on the body. And this is coming from our lifestyle choices and our exposure to toxicity, environmental toxins, and poor detoxification pathways, and of course, most importantly, a suboptimal lymphovascular terrain. According to osteopath Torsten Lehm, allostatic load affects the cardiovascular system in the form of hypertension, left heart hypertrophy, arteriosclerosis, fibrin system disinhibition, and elevated risk of myocardial infarction. Allostatic load will affect the nervous system by leading to behavioral changes such as depression, cognitive capacity reduction, and memory with loss of anxiety. That's already been mentioned once before. Allostatic load can lead to insulin resistance, increased blood pressure, hyperlipidemia, hyperglycemia, and metabolic syndrome via the adaptation of the endocrine system. Allostatic load can affect immune system responses such as T-cell activity suppression. Allostatic load can affect the adrenergic steroid system by contributing to insulin resistance, tissue oxidation, disturbances in bone metabolism, as well as glucose and fat metabolism. So let's isolate one measurement of allostatic load in the context of obesity or fat deposition and weight gain, keeping in mind that fluidic retention is often associated with weight gain and inflammation. Here we're talking about edema. If the detoxification pathways are overwhelmed, then the fluids produced by the body as a metabolic byproduct will be stored in various parts of the body as edema. These areas of the body that are storing edema are known as a stasis or a lymphostasis, and they are often areas where there are pressure gradient imbalances. In my clinical observations, I've noticed that what many patients identify as weight gain is a combination of fluid retention and fat deposition. Fluid retention presents differently than fat deposition. Fat presents as tissue that is dense, and fluid expresses itself to more subtle palpation or oscillations. For example, Tapping on the surface layer of a pond, you can see the movement or waves emanating from the site of contact. Similar observations can be made with human tissue. The fluid retention or edema is a phenomena of pressure gradient imbalances and metabolic insufficiencies. That's coming from Bruno Schickli. It's important I distinguish between injury-related edema and non-injury related edema. For the purposes of this presentation, I'm referring to non-injury related edema. In terms of edema and allostatic load, edema is a swelling caused by too much fluid trapped in the body's tissues. Edema can affect any part of the body, but it's more likely to show up in the legs and the feet. Medicines and pregnancy can cause edema. It also can be the result of a disease, such as a congestive heart failure, kidney disease, venous insufficiency, or cirrhosis of the liver. Typical causes of edema provided by the Mayo Clinic website at mayoclinic.org. Edema can be a side effect of some medicines. These would include high blood pressure medicines, non-steroidal anti-inflammatory medicines, steroid medicines, estrogens, certain diabetic medicines, and medicines used to treat nerve pain. Symptoms of edema include swelling or puffiness of the tissues right under the skin, especially in the legs or arms, stretched or shiny skin, skin that holds a dimple, also known as pitting, after it has been pressed for a few seconds, increase in the size of the stomach area, such as bloating, and feeling of leg heaviness. Pathophysiological causes of edema provided by the Mayo Clinic website. Congestive heart failure causes one or both of the heart's lower chambers to stop pumping blood well. As a result, blood can back up in the legs, ankles, and feet, causing edema. Congestive heart failure can also cause swelling in the stomach area and also can cause fluid to build up in the lungs, known as pulmonary edema, leading to shortness of breath. And liver damage. This liver damage from cirrhosis can cause fluid to build up in the stomach area and in the legs. This fluid buildup in the stomach area is known as ascites. Typically what happens in the case of blood being stored in the legs is that it interferes with the lymphokinesis, meaning that the increased pressure causes the body to disrupt the lymphatic flow in the area. Other pathophysiological causes of edema provided by the Mayo Clinic website. Kidney disease. Kidney disease can cause fluid and salts in the blood to build up. Edema linked to kidney disease usually occurs in the legs and around the eyes. Kidney damage. Damage to the tiny filtering blood vessels in the kidney can result in nephrotic syndrome. In nephrotic syndrome, decreased levels of protein in the blood can lead to edema. Weakness or damage to veins in your legs. This condition, known as chronic venous insufficiency, harms the one-way valves in the leg. One-way valves keep blood flowing in one direction. Damage to the valves allows blood to pool in the leg veins and causes swelling. Other pathophysiological causes of edema coming from the Mayo Clinic. Deep vein thrombosis, also called DVT. Sudden swelling in one leg with pain in the calf muscle can be due to a blood clot in one of the leg veins. DVT usually requires medical help right away. Problems with the system in the body that clears extra fluid from the tissues. If the body's lymphatic system is damaged, such as by cancer or surgery, the lymphatic system might not drain well. It's important also to consider, although I've been talking about the various diseases that occur with kidney, heart disease, or liver diseases, there's a progression that precedes those diseases, meaning that the function of these various organs can slowly decrease or lose their viability. The diseases don't typically show up overnight. They happen over a trend. So if we're losing some of the function or adaptability or capacity of the liver or the heart or the kidneys, you can see how edema will gradually increase over time, which might explain why there's a presence of edema as people age, and they may not even have a full-blown liver, heart, or kidney disease, but they have an overall breakdown in the detoxification pathways. It's important that, as I mentioned here, the Mayo Clinic does talk about the lymphatic system as not draining appropriately. So here I'm talking about the lympho-vascular system and the various pressure gradients in the body. When you start to get alterations in tone in either of the heart, the liver, or the kidneys, or in some cases the small intestine and its ability to properly absorb and transport blood via the portal vein back to the liver, you can see why edema can collect in various aspects of the body and can be a strong indicator that an individual is in allostatic load. In addition, there's a severe long-term lack of protein. An extreme lack of protein in the diet over time can also lead to edema. According to the Mayo Clinic, there are some complications that will be the result of edema that is left untreated. This includes swelling that gets more and more painful. Now, the pain is coming from chemoreceptors being triggered due to a toxicity overload in the region. This can lead to problems walking and especially joint stiffness upon waking. Many people look at this as arthritis, but it could simply just be toxicity due to the fact that it builds up overnight, where you have poor drainage because the body is not moving sufficiently enough to help with lymphokinesis. The lymphatic stasis will collect most commonly in the feet or in the hands, or in the extremities where it's more difficult for the body to properly support lymphokinesis and drainage and detoxification during the evening. You can have stretched skin, which can also be itchy, which is another sign that the lymphovascular terrain is being overwhelmed in a specific area. And the itchiness can come without any visible redness or discoloration of the tissues. This also will increase the risk of infection in swollen areas. You will also get scarring between layers of tissues due to the adhesions that occur between these layers. Less blood flow means less ability of the arteries, veins, joints, and muscles to stretch, also contributing to the stiffness. The osteopathic view on edema, coming from Bruno Schichli, he defines it as an accumulation of excessive fluid in the tissues and as hydrocolloid in the body. In particular, it is a swelling. In the case of local edema, we can include those that involve excessive buildup of fluids that occur in various body cavities. When there's an accumulation of fluids in the peritoneal cavity, it is referred to as ascites. When it occurs in the pleural cavity, it is defined as hydrothorax. When it occurs in the pericardial cavity, it is known as hydropericardium. When it occurs around the testes, it is called hydrocele. When it occurs in the oviduct, it is referred to as hydrosalpinx. I believe we could rely on the presence of non-injury related edema to inform us on the potential level of allostatic load. The designation of edema as an osteopathic lesion itself can certainly inform the clinical directive. The concept of an osteopathic lesion is used as a form of classification of holding patterns or blocked circulation affecting either joint mobility or organ motility and overall function. It's used to describe relationships within the body that the practitioner would endeavor to correct, and not as a description of a growth of some kind, which the word lesion is typically associated with. Circumscribed edema and relative acidosis are often found in the layers of superficial fascia, where there is participation of the subdermal lymphatics. This distinctly doughy feeling, found upon palpation, is implicated in the existing factors of uncovering an osteopathic lesion. Typically, the area of enlargement or edema includes toxins or infection, and it is often accompanied by dysfunction in the nearby lymphatics, and that's coming from osteopath Tom Dummer. Additional perspectives on edema from the osteopathic tradition come from Millard. He states, no organ or ductless gland can be involved to any great extent without reflecting its disturbance and blockage on some palpable area. We must look for edematous areas. There are certain areas that denote specific organic lymph blockage. The watching of these regions that are prone to puff is very essential. Learn to detect puffy areas, and that's written in 1922, his observations. I think what's important here is that the consideration of using edema as an indicator of a type of a osteopathic lesion, ultimately something involving a lymph blockage, can be happening at any level in the body. I think it can be an important tool in understanding the trend in the terrain of the human physiology, and also a decent indicator of potential level of allostatic load that an individual is complaining about. Foldy defines the clinical definition of edema as a swelling that is the result of an increase in the amount of fluid situated in the interstitium that is visible or palpable to our senses. Extracellular edema can be accompanied by intracellular edema in cases of mechanical and combined lymphatic vascular insufficiencies. Edema must be categorized only as a symptom and not a diagnosis, except for mechanical insufficiencies contributing to diagnosed lymphedema. His reference of mechanical insufficiencies is discussing more the territory of damaged lymphatic vessels or valves leading to the presence of lymphedema over time. But we can also extend that and use the word mechanical from the point of view of the pressure gradients in the body and the role of, for instance, the heart and the diaphragm and the liver as contributing to the pressure gradient mechanics and circulatory mechanics of the body. And as I discussed before, if there's suboptimal positioning of the diaphragm and associated limitations in liver function or heart function, cardiovascular function, then that certainly would be considered more of a mechanical or, shall we say, structural component that the osteopathic tradition has every potential to resolve and manage. Looking at categories of edema, edema can be regarded as a high protein or a low protein and localized or generalized edema, which can further be classified into 4 subgroups: generalized high protein edema, generalized low protein edema, localized high protein edema, localized low protein edema. When the entire body is affected by edema, it is defined as a generalized edema. The classification of high and low protein edema is based on protein concentrations in which various edema fluids can be compared to each other. Additional examples of edema, which I'm not going to go into great detail to pronounce, most of them are all tongue twisters, but you can see that when you're examining areas, the brain, the eyes, the heart, the lungs, the liver, the kidneys, in the intestinal tract, the testes. Further, you can go into the body cavities, the periosteum, the ligaments, and including the tendons, which initially you have the example of lymphostatic tendinitis. What's important is that many of the itises in the body are going to have some lymphatic stasis in the area, which would be examples of edema. Again, the non-injury related edema that I'm talking about. Other common areas of lymphostasis and edema would be in the joints, around the nerves, lymph nodes themselves, lymph vessels, and blood vessels. All these areas can have lymphostasis in the area, leading to triggering chemoreceptors and pain receptors, and presenting as chronic conditions that would fall into the itis category. We can connect the term lymphostasis with edema, as they are basically the same phenomena, meaning that if we promote as practitioners or improve lymphokinesis, we can thereby reduce the level of edema. There's evidence that controlling the inflammatory process depends on the ability of the lymphatic system to remove and deactivate chemical and immune mediators. These mediators control the process of inflammation. Disease that depends on lymphatic drainage for resolutions include asthma, pancreatitis, rheumatoid arthritis, and myocardial infarction, and that's coming from Seffinger. Tissue degeneration will be the result of prolonged inflammation as well as smoldering infections and tissue destruction brought on by chronic inflammatory processes. There is also evidence that the removal of cytokine, leukotrienes, prostaglandins, bradykinin, and histamine is dependent on the proper function of the lymphatic system. Some of the most recent studies on inflammation is coming from gastroenterologist Shipla Ravella. She says there appears to be a cost for our modern environment and its various elements of toxic overload in the form of what she calls hidden inflammation. In her words, the biomedical framework of the 19th century divided organ systems and on understanding that a specific cause results in a specific disease is no longer effective for most health conditions that plague us today. Effectively combating hidden inflammation begins in delving deep into root causes. Human genetics, which have remained relatively constant or longer lifespans, cannot alone explain the steep rise in chronic inflammatory diseases over the last decades. our destinies are largely shaped by lifestyle. Examples of hidden inflammation. Typically, hidden inflammation can be located alongside organs and in specific spots throughout the body, including inside various vascular and lymphatic vessels. Lifestyle diseases have a cynical nature as the metabolic implications play themselves out within the ecosystem of the human body. Lurking beneath in various tissues, we can have a process of complex physiological degeneration in the form of developing tumors, heart disease, diabetes, obesity, psychiatric, and especially neurodegenerative diseases. There may be few signs or symptoms of hidden inflammation as it smolders away, occasionally expressing itself as autoimmune disorders, arthritis, eczema, psoriasis, chronic pain, or swelling with redness or heat. That's just to name a few. My perspective on the disease process, it's important to ask the question, was the arrival of a disease precipitated by edema, allostatic load, terrain fatigue, and/or many chronic non-disease states that produce various symptoms prior to turning into a disease? Consider that the lymphovascular terrain provides the ecosystem for both function and dysfunction. Ask the question, is there a physiological tipping point that shifts the health trend of the terrain towards disease? Often, what I call a surprise disease occurs within normal homeostatic parameters, presenting undiagnosed until it's too late. From a therapist's point of view, we want to pay attention to edema and develop the skills to recognize its typical qualities. We should endeavor to improve the ecosystem or physiological environment of the body by influencing the lymphovascular terrain and supporting the detoxification pathways. Improving the function within the ecosystem aligns with epigenetic factors of a toxicity in the environment, potentially influencing genetic activation towards a disease state. Additional manual therapy solutions: removing tissue and organ resistance, which limits blood flow, as it will allow for normal lymphokinesis, ideal expression of detoxification pathways, and optimal immune responsiveness. In short, restoring adaptability and viability. Consider that the root cause of osteopathic lesion patterns may be a guarded response of connective tissues, organs, and joints organizing around the vascular tree in an attempt to sustain blood flow. A useful observation we can make as practitioners is the observation of patterns that occur in the people that you see in your practice. These can be postural deviations, movements such as gait deformity, emotional patterns, and even some behavioral patterns. Path Nicholas Handel has an interesting perspective on pattern recognition. When the body compensates for trauma, it will attempt to escape by distorting itself and thereby contributing to a pattern. The adaptation always strives to maintain the inherent motion that is expressed by the PRM, or primary respiratory mechanism, and the CRA, the cranial mechanism, or whatever tidal movement expresses itself in the organism. The adaptation will always endeavor to a structural/functional relationship of least resistance despite the distortion. The pattern allows the body to organize itself with the best opportunity to maintain homeostasis via physiological adaptations. The pathology is introduced when the pattern no longer expresses any inherent motion or physiological adaptation. So to me, what this is saying is that as the body is adapting, the number one priority is to sustain blood flow. The body is limited in its adaptations. It tends to contract or tighten when it's trying to sustain blood flow. It does not open as readily. Once the system gets activated into a guarding mechanism, then you start to get your stasis. That's when it's an indicator that the lymphatics are not properly functioning in the area. And we know that the pressure gradients have an enormous impact on lymphokinesis. So if you have aspects of the physiology at any level that are in a guarding mode, whether that's acquired from direct trauma or surgeries, or typically developing over time as an expression of lifestyle choices or habits, then we know that we've got some issues related to pressure gradients and lymphostasis. Again, we have British osteopath Nicholas Handel discussing his viewpoints of adaptation. Most patients have their own unique mixture of each pattern in varying degrees. Patterns are named according to the direction into which the mechanism distorts most easily, taking the path of least resistance. In other words, the mechanical configuration in which that individual prefers to function will tend towards that direction of that pattern towards the ease. Adaptational patterns are not the same as trauma occurring from a direct insult, such as motor vehicle accidents, surgery, concussions, falling down a flight of stairs, or a bicycle accident. One way to interpret this viewpoint is to go back to the first principles of osteopathy defined by Dr. Andrew Taylor Still, and that is that the artery rules or reigns supreme, meaning that blood flow reigns supreme and that the body will adjust to sustain blood flow. When adaptations go towards ease, they do so to protect blood flow. Also, when tissues go into contracture, this is also to protect blood flow. This is not necessarily the case with a direct insult traumas, as Handel has mentioned. Expanding on the concept of adaptation, including organs and tissues, the interrelationship between structure, function, and form are represented in the organization, exchange, and origin of the tissues. Hence, it is important that the osteopathic practitioner remember that the principles of osteopathy come from the principles of life. The magic of life lies in the fact that tissues involved in a successive stage of embryological development of form and structure contain the embodiment of a plan that precedes their arrival. All of this being modulated by a persistent interference between the epigenetic factors and the morphogenic fields. The underlying genetic pattern of expression is constantly receiving interference within the extracellular matrix from epigenetic and environmental impulses in the time and space relationship. It seems the pattern continues into adulthood and throughout our lives underneath the biochemical, anatomical, physiological exchanges. The expression of the human body plan can be considered a sequential process of a linear molecular morphogenic event. In addition to this perspective, it's worth noting that the body plan is also a continuous dynamic exchange amongst field patterns and the organs themselves. The shape of organs and tissues contribute to their functional capabilities. Now, this is coming from Lean, as he discusses the shape of organs and tissues contributing to their functional capabilities. I think it's important to consider that restoring this shape is going to improve function. And it appears that what Lehm is talking about, which is coming from the Blechschmidt school of embryology, is that there is a purpose in the shape that our organs contain, and that through a loss of adaptability, our organs are losing some of their shape and their ability to function optimally. Again, according to Tom Dummer, there is a movement of forces between that which is trying to express its divine potential and the influence of the environmental forces which contribute to the adaptation. Ontogenetically speaking, life is a process of unfolding stemming from the integration and adaptation to the surrounding environment. Genetics are only a part of the dynamic, and they do not work in isolation. It is possible that morphogenic fields operate as mediators between the phenotype and the genotype. The cell is a unit of organic function and structure. Intrinsically activated motility occurs prior to the reaction to external stimulation in both phylogenetic and embryological development. It is observed during embryogenesis that the body will act first before reacting, as in the case with myogenic movement preceding neurogenic action. An example is muscles acting and reacting prior to having any nervous connections. So the body appears to be responding to its environment before getting any information from the nervous system, which I think is part of the connective tissue intelligence system that has gained popularity in recent research. I believe what predisposes the muscles to react prior to proprioceptive mechanisms is the propensity to protect blood flow within and to the muscle in question. We know that embryologically speaking, the connective tissue matrix arrives in the form of a lattice or support structure to receive the arterial development. Connective tissue is predisposed to enhance, support, and protect blood flow first, prior to any development messaging from the brain or the nervous system. Looking at some solutions to manage these patterns. The goal as a therapist is not to change the pattern, but to allow for the information necessary to change the pattern to present itself in the tissues under our hands. Many disturbances are of a functional nature where there are no traditional medical findings, and the ones that do exist are hazy at best. As a result, there is no clear diagnosis to indicate the exact approach to therapeutic intervention. From Lehm, quoting, "Osteopathy therefore deals with a gray area situated between medically relevant symptom complexes and the associated diagnoses. I suggest that in the industrialized societies, this gray area appears to be growing." It's my belief that the gray area that Dr. Torsten Lehm references is situated in the health dynamics of the lymphovascular terrain. Also appears that the mechanism of allostasis is also located primarily within the lymphovascular terrain. This terrain is where the trend from inflammation towards tissue degeneration primarily occurs. Dr. Lehm does refer to the gray area as terrain as well. Practitioners are trained to impose ourselves onto the existing physiological relationship of dysfunction and alignment of our patients. We locate lesions with biomechanical patterns, and we approach them directly with varying techniques and adjustments. Job well done. except when the problem lies in this gray area. We are taught to exclude the gray areas and pinpoint black and white relationships. Successful treatment of the terrain or gray area lies in obtaining the correct roadmap, understanding the direction of flow systems within the ecosystem of the body, and being the right tool for the body. Sephinger talks about lymphovascular terrain dysfunction. Pathogens were once microbes that developed further mechanisms leading to an increased virulence factor. Disease requires that the pathogen overcome the host's genetic, physical, cellular, microbiological, and biochemical defenses. Microbes are opportunistic in that they will take advantage of the impaired defenses of the host and cause disease. The key to preventing infection is to better understand the microbial pathogenesis and immunology potential of the host. According to the American Osteopathic Association, to cause an infection, first, the microbe must gain access to the host via breach of defenses. These defenses may be other microbes which inhabit the same niche on the human body. According to the father of osteopathy, Dr. Still, the fascia proves itself to be the probable matrix of life and death. By its action we live, and by its failure we shrink or swell and die. For in this fertile soil, disease germinates and develops the seeds of sickness and death. He also stated that the body's circulating fluids must be free to remove dead substances before they ferment in lymphatics and cellular systems. Some solutions for addressing lymphovascular terrain dysfunction. The ideal tool to manage lymphovascular terrain is one that supports restoring ideal conditions within the terrain. Local and regional changes will support systemic changes. We want to improve blood flow. We want to open up detoxification pathways. We do this by correcting pressure gradient imbalances, correcting tensegrity imbalances, restoring shape, position, and the ideal tone to organs and various structures. We also want to restore the ideal microbiome composition to the mucosal layer portion of the lymphovascular terrain. Looking again at the dynamics of health, when homeostasis or self-organization is under duress, it will trend towards allostasis or entropy. Many lifestyle-related health complaints and dysfunctions are expressions of allostasis and have yet to develop into pathology. This health dynamic of allostasis will be represented in the terrain or gray area as dysfunction, chronic symptoms, and can eventually evolve into tissue degeneration. The role of the practitioner is to provide the ideal fulcrum for the self-actualization of tissues and structures, which allows for homeostasis to self-organize with less resistance. Ultimately, we want to have a positive effect on the immune system and resiliency. There are three complex interconnected systems in the human body which respond to the invading pathogens. These are barrier immunity, adaptive immunity, and innate immunity. Barrier immunity examples include the skin and all the mucosal surfaces inside the human body. Gastric acidity is also acting as a barrier of sorts. The skin contains antimicrobial peptides that contribute to the microbiota, and it is the body's largest protective barrier. The skin contains tiny finger-like cells called dendritic cells, which can smother invading microbes and transfer them to the lymphatics below for elimination. Disease can occur if the lymphatic flow from the tissues is impaired. There are extensive microorganisms interacting on the human skin, acting as immune defenders. Once the barrier immune response is breached, the innate immune system is activated to recognize a wide range of familiar patterns that leads to the phagocytic ingestion and elimination of pathogenic invaders. This occurs via pattern recognition receptors. The adaptive immune system is interconnected to the innate immune system as the body strives to create an effector cellular response. The adaptive immune system provides a secondary response that is more specific but takes longer to fully develop into effectiveness. Further decision of the adaptive immune response will be made of a humoral antibody response and a cell-mediated immunity. There are specific areas of the lymphovascular terrain which are the first line of defenses for our immune response. Let's look at the complexity of the mucosal layers and their role as such. Intestinal mucus immunity. The intestinal mucus layer has a primary role in intestinal protection against mechanical, chemical, and biological attacks and contributes to the maintenance of intestinal homeostasis. It creates a coat that covers the intestinal cells, protecting them from contact with external and toxic substances, digestive enzymes, and bacteria. The important protective function of mucus stands out from its continuous secretion into the GI tract, approximately 10 liters per day. Recent studies on mucus reveal the mucus layer not only acts as an important factor for protecting the host against microbial invaders, but also contributes to the mutualism between the host and microbes. Many diseases are associated with the alteration of the mucus layer thickness, but it is still difficult to identify whether this effect is a cause or a consequence of the disease. Additionally, recent evidence suggests that specific gut microbes contribute to the regulation of the mucus barrier and eventually intestinal and host health. The gut microbiota is part of the terrain. The gut microbiota strongly contributes to modulate the intestinal mucus layer. Gut microbiota are required to activate specific enzymes for optimal absorption. The composition of the gut microbiota undergoes changes from the mucosal to the luminal fecal side, as observed in both humans and mice. Luminal and mucosal associated microbiota are different ecosystems with different microbial diversity and compositions, as well as metabolic and immunological functions. Modifications in the microbiome may be associated with psychiatric and neurological conditions such as anxiety, depression, delirium, and psychosis. There are several neuroactive and immunomodular compounds that are produced by bacteria which play a role in brain function. These include histamine, serotonin, dopamine, and acetylcholine. The vagus nerve operates as a messenger for connecting the bacteria signaling to the brain to the neuroenteric axis. The result of inadequate gut microflora can lead to abnormal behaviors as well as neuroendocrine responses that will in turn reshape the composition of the gut microbiota. Moving away from the microbiome, I'll discuss the connective tissue intelligence that embodies the terrain. Embryologically speaking, the vascular and lymphatic vessels originate within the connective tissue layer, and connective tissue is highly vascularized. Connective tissue divides, surrounds, and guards almost all structures in the body. It acts as a transportation highway for nutrients and helps insulate the body by storing fat. The connective tissue is capable of combating pathogens and of generating a microelectrical current within the ground substance. The structure of the tissue is made up of ground substances called the extracellular matrix and fibrous cells. That's coming from Bruno Schichli. connective tissue neurology, according to Robert Schleip, the overall total surface of fascia in the body includes membranous pockets and millions of endomysial sacs that by far exceed the surface area of any other tissue. Fascia contains 10 times the amount of sensory nerve receptors than the muscular tissue muscle spindles. Additionally, there are also several different types of sensory receptors, such as the mostly myelinated proprioceptive, Golgi, Ruffini, and Puccini endings. There are also numerous small unmyelinated free nerve endings that are found in the visceral connective tissue and the periosteum. Some of those unmyelinated nerve endings would include portions of the vagus nerve that contributes to the polyvagal theory. Connective tissue histology. All tissues in the body participate in forming a type of living sponge, whose role is to facilitate the containment and migration of fluid concentrations and pressure gradients. The open cell foam networks are a description used to describe the reaction of cells to mechanical compression stress as the filaments of the cytoskeleton are distorted and bent. So you can see here when I'm using the description of a metabolic sponge, I'm getting this from Torsten Lehm. Defining fascia versus connective tissue. Fascia can be defined as the soft tissue component of the connective tissue system that populates the entire body. The entire connective tissue network includes dense septa, aponeuroses, joint capsules, retinacula, ligaments, and tendons. It also includes soft collagenous connective tissues, such as superficial fascia. In addition, the dura mater, perineurium, periosteum, organ capsules, vertebral disc fibrous capsules, mesentery of the abdomen, and bronchial connective tissues have all been classified as fascia. Most recently, connective tissue research also classifies blood, lymph, bone, and cartilage as connective tissue, since they all originate in embryological mesenchyme. Continuing on with fascia, in addition to the basic definition, the American Osteopathic Association has expanded the definition of fascia as being the largest organ in the body, as it includes the vascular system, the lymphatic system, and the drainage of fluids, as well as innervation. And this is exactly this complex that I'm describing as the lymphovascular terrain. However, this excludes the tendons, ligaments, and aponeurosis, as they are of a different histological composition and can be viewed as connective tissue. The four primary layers of fascia are panicular, superficial fascia, axial, deep fascia, meningeal, which surrounds the nervous system, and visceral fascia. Looking at the extracellular matrix part of lymphovascular terrain, the term extracellular matrix is applied collectively to extracellular components of supporting connective tissues. The matrix provides the distribution of mechanical stress on various tissues and provides a framework for cells attaching to it. The matrix is a highly hydrated medium through which metabolites, gases, and nutrients can pass freely between cells and transversing nearby blood vessels. The extracellular matrix can adapt and react to changes in its environment by producing a rhythmic contraction pattern. It is composed mainly of fibers and a gel-like ground substance. This organized network provides support for cellular attachments. In conclusion, the human body, with its lymphovascular terrain and myriad of connective tissues, behaves like a self-organizing system, a type of living bioplasm matrix, a type of metabolic sponge of varying degrees of densities and variations. When we add the dynamics of homeostasis and allostasis to the nature of human physiology, we can perhaps explain the tendency towards regeneration and healing. For this explanation, I'll also look to the great scientist Ilya Prigogine, who was a Russian-born Belgian physical chemist who received the Nobel Prize for Chemistry in 1977 for contributions to non-equilibrium thermodynamics. Prigogine's work dealt with the application of the second law of thermodynamics to complex systems, including living organisms. The second law states that physical systems tend to slide spontaneously and irreversibly toward a state of disorder, a process driven by an increase in entropy. Prigogine argued that as long as systems receive energy and matter from an external source, nonlinear systems, or dissipative structures, as he called them, can go through periods of instability and then self-organization, resulting in more complex systems. Self-organization in dissipative structures, according to Prigogine, it is precisely the forces of entropy and disorganization that permit pathophysiological presentations. There is a self-organizational quality that is a potential within dissipative structures to produce order out of chaos. A dissipative structure is an open system which is thermodynamic by nature, and it also exchanges energy, matter, and information with the external environment. However, the system itself or any portion of it does not necessarily operate within a thermodynamic equilibrium. If we look at the forces behind physiological life within the human being, I look at this as being the software or program working on behalf of the hardware, which we can view as the physical body itself. In conclusion, thank you for your interest in this topic. I hope you enjoy my next presentation, which will be on the cranial and cervical lymphovascular terrain, where I will go into great detail on the lymphatic systems and the associated deep and superficial lymphatics that support the cranial sphere. References are to follow. Thank you.